Good morning, everyone. I think people are they're still filtering in, but we'll go ahead and get started. So welcome to day 3 of our 8th International Symposium on Focused Ultrasound. I thank you all for joining us. I'm Jessica Foley, the Foundation's, do you want this or do you want to? Okay. I'm Jessica Foley, the Foundation's Chief Scientific Officer, and today we have a very exciting program. First we'll highlight, we have a lot of different topics, but first we're going to have 2 exciting panels on cancer immunotherapy. Then we'll have a discussion on a variety of technical topics. We'll have a special Women in Focused Ultrasound luncheon, and we'll close with special lectures on reimbursement and a fireside chat with regulatory consultants. So as a reminder, all oral presentations have been pre-recorded and made available to you to watch on the virtual platform. And we encourage you to view these impressive presentations that are highlighting the latest and greatest focused ultrasound clinical, preclinical, and technical work, and as well to interact with presenters via the discussion tab on any of those recordings. So now we'll begin with the first of 2 panels on cancer immunotherapy, Where Are We Now?, where panelists will discuss the current state of the field for immune-based focused ultrasound therapies. Dr. Tim Bullock from the University of Virginia will moderate this panel. Go, Tim.
Thank you, Jessica, and good morning, everybody. Welcome to your early morning stimulation with immunology. It doesn't get more exciting than this for the rest of the day. It's my pleasure to be the moderator of this panel, and we're going to have 2 cancer immunology panels. The first one, which I've been tasked with, is really talking about the state of the field where we are now. As for a long period of time, there's been this expectation that focused ultrasound and the energy that it delivers to the tumor microenvironment has a tremendous amount of potential for modulating that environment to increase the immunogenicity of it. And we're going to explore some of those characteristics this morning and have some discussion about what are the barriers that we are perceiving are in place that are potentially limiting the efficacy of focused ultrasound, and really some of the outstanding questions about the regimens and the status of, or the application of focused ultrasound so that it reaches its full potential in primary preclinical models at the moment, although it's exciting to know that clinical trials are now underway using focused ultrasound with the intent of promoting patient immunity. I'm supported today by a wonderful group of researchers who are experts in this field. And we have, on the table with us here, we have Dr. Tao Sun, who is from Brigham and Women's University Hospital, whose expertise is in the use of the application of focused ultrasound in glioblastoma, but also is exploring Alzheimer's, I read recently. So he's a dual threat. We have Dr. Joe from the NIH, who is going to be providing us information about the use of pulsed ultrasound, focused ultrasound, and some of his studies have been really looking at different models and how they compare. And we have Dr. Awndre Gamache from the University of Virginia, who's been working with pancreatic cancer. And if they're awake, we have, from the West Coast, we have Dr. Tatiana Khokhlova. It's 5 a.m. in the morning there, so please be respectful for them. And she's at the University of Washington, and she's joining us virtually, along with Dr. Ferrara from Stanford University. And we have Dr. Allen, who has no excuses about not being awake, because he's just down at Virginia Tech. There he is. So they're all going to be chiming in, and we're going to be having hopefully a lively discussion about their insights and experiences with where they are in their studies with focused ultrasound in different disease states. So I'm going to get started just by really trying to break down in the first few minutes the immunology of where we think, or the cancer immunology of where we think focused ultrasound has the opportunity to intersect with cancer immunotherapy. And the slide that's we're looking at now shows multiple stages where this can be occurring. And we have the deposition of focused ultrasound in multiple different formats, in different regimens, different intensities, that I think is an interesting discussion point with respect to how they may be perceived by both the cancer, the immune system that is integrated with the cancer, the stromal cells, and then downstream. But one of the primary hypotheses is that, well, the second event that has to happen for the immune system to recognize cancer is that antigens or protein targets within cancer cells have to be released, have to become available to be seen by the immune system. And this is generally achieved by a very specialized cell in the immune system called the dendritic cell. These dendritic cells are commonly found within cancers, and the absence of them within cancer is a known prognostic indicator of poor outcome for patients. They need these cells to be within their cancers because they're going to acquire this information, the Achilles heel, if you will, of cancers, in that the genetic variability and the genetic instability that occurs within cancers leads to the acquisition of point mutations within the genome, and those point mutations are read out as alterations in amino acid sequences, and those alterations in the amino acid sequences become targets for the T cells within our body to recognize and respond to. So T cells are really sensitive to the alterations in amino acid sequences within proteins, within cancer cells. So this antigen, these amino acids, have to be acquired by dendritic cells, and then they will transport themselves with their cargo of information down to the draining lymph node. And in the draining lymph node, there is a variety of events that occur that result in the recruitment of naive T cells to those dendritic cells. They're sort of encouraged to come visit, and they'll screen those dendritic cells for the opportunity of their T cell receptor, which is an exquisitely sensitive and specific antigen receptor on the surface of the T cells for the evidence of these amino acid changes within the tumor cells, at which point they can become activated. An activated T cell undergoes both proliferation, expanding in numbers, and also differentiation. It has the option of becoming cytotoxic cell with great capabilities of causing lysis of the target cells, or it can produce cytokines that can impede tumor growth. All of these events, we understand, occurred primarily down in the lymph node, but it needs a certain degree of context for this differentiation to occur. And that's really the degree of inflammation that is in play as the T cell becomes activated. And that information is also commonly imparted by the dendritic cell. So not only does the dendritic cell give the specific information to the T cells to say, there's something dangerous out there, you need to go investigate, but it also says, how dangerous is it? And that's the information that comes from the dendritic cells. And without that high degree of danger, then the immune system actually turns itself off. So it's a highly dynamic, informational-based interaction between the dendritic cells with the tumor antigen and the corresponding T cell response. Once T cells have become activated, though, they undergo their proliferation, and they're permitted to leave the lymph node, and they upregulate a series of integrins and chemokine receptors on their surface, basically traffic signals, that allows them to go find where the insult is, whether it's a pathogenic infection or, in the case of all of our studies, the actual cancer cell or the cancer deposit. And you can imagine it's sort of like going around the beltway. You need information where to get off. Where's I-95? We've got to get off 495, right? And that's what the chemokines and the integrins do. It gives the information to the T cell to say, okay, here's Bethesda, let's get out. And once the T cell gets into the tumor microenvironment, it can then use its T cell receptor to recognize the original antigen that was presented by the dendritic cell. So you have that cognate interaction that was initiated down in the lymph node, now coming into play again at the tumor deposit. And then that gives the T cell the opportunity to produce its cytokines and the cytolytic activity that can impede the tumor growth. So that's kind of the nuts and bolts of what's going on in the tumor environment. And of course, if that was all happening, we wouldn't be here today because cancer grows. And so we've learned over the last 30 years or so that there are multiple mechanisms by which T cells can be incapacitated in the tumor microenvironment. Those can be factors secreted by tumors, the competition for metabolites or the production of metabolites by tumors, and a variety of natural defense mechanisms that really are designed to prevent the immune system being really dangerous to our body. as immune cells become activated, the factors that they secrete are highly inflammatory. That's very, very dangerous to the host if it's uncontrolled. And so there are a variety of mechanisms, both cellular and molecular, that will lead to the incapacitation of T cells. And those are exploited in the tumor microenvironment. There is a natural selection in play for tumors that have the capability of deploying these defense mechanisms. And the whole basis of cancer immunotherapy over the last 20 years has been understanding those defense mechanisms and breaking them down, primarily with antibodies. And that's the basis of checkpoint blockade immunotherapy that has revolutionized cancer therapy over the last 10 years or so. So where is focused ultrasound really most likely to play? Everywhere, right? There's opportunities at each one of these stages for the immune system to recognize or to be promoted by focused ultrasound. The damage that is induced by ablation can lead to greater antigen production, and that antigen should be accompanied by what are referred to as damage-associated molecular patterns, or molecules that are recognized by the innate system to say there's something dangerous going on here. And those should also be released as a function of doing damage with ablative techniques. We would anticipate that dendritic cells would also be mobilized and traffic from the tumor microenvironment by the insult that comes along with focused ultrasound, and a higher degree of antigen availability due to the destruction of the immune cell, of the tumor cells. And then, of course, there are questions about how is the tumor microenvironment itself directly changed by the ultrasound. The ablative activity of the ultrasound is the destruction of the tumor cells and potentially the fibroblasts and the other stromal cells in that environment, now making that tumor more permissive to T-cell infiltration and function in that environment. Have we eliminated the cells that are likely to be immunosuppressive, revealing more opportunities for the immune cells to have their activity in that tumor microenvironment? So that's the sort of stage where we start at. And we've had a few workshops over the last few years trying to understand what are the best opportunities, what are the known unknowns in the space of cancer immunotherapy at the interaction of focused ultrasound. And as a community, we've been trying to understand biomarkers of response, both at the level of how is the focused ultrasound being perceived in the tumor microenvironment, what sort of cytokines have been produced that indicate that the appropriate type of a destruction is occurring that is going to elicit an immune response, a productive immune response. We really are asking the community to come up with details or provide details of sonication strategies that are readily available and interpretable across the community, and so that those there can be a correlation between the biomarkers that have been investigated with the regimens that have been used by the focused ultrasound instrumentation. We have questions about treatment frequency. Is a single ablation sufficient, or do we need to be using what is possibly one of the greatest powers of focused ultrasound in the fact that it's non-ionizing and allows the potential for repetitive treatment? And is that advantageous, or is that disadvantageous in the fact that it may promote a fibrotic response, for example? And as we have begun to interlace focused ultrasound with cancer immunotherapy, many questions are in play about what are the most immune adjuvants to be considering as we think about leveraging the capabilities of focused ultrasound. If it's not entirely successful as a monotherapy, what are the strengths and weaknesses of the response to the focused ultrasound, and how can we integrate that knowledge with the selection of immune interventions that we now have in our armamentarium to fully leverage the advantages that come into play as we use focused ultrasound for tissue damage. And so we have, it doesn't quite fit on the slide here. We have had some very interesting observations over the last 5 to 10 years or so, in that some studies from Joe Frank's lab, for example, have begun to analyze how do different tumors respond to the same treatment regimen. I think that's an incredibly important question, and we'll have some of that discussion today. Is the damage perceived in exactly the same way by different tumors? Consistent with that, we've had some nice studies by Ferrara's group beginning to understand the transcriptional differences that occur with different modalities as they're put into the tumor microenvironment. And that transcriptional information can give us really important insights into how the tumors are responding acutely and durably with respect to the focused ultrasound regimens. There's been some really great studies coming out of Zhenzhu's group up in Michigan, where they actually look at different treatment types, not just focused ultrasound, but actually compare that to radiation, to IRE, different ways of doing destruction to tumors, to give us some idea of the context by which these different energy treatment regimens can result in different qualities and quantities of immune responses to the tumors. And then as we move forward into considering rational combinations, there's been some lovely studies down in from Ranchan's group looking at CD40 stimulation, which is a great way of activating dendritic cells, and how that can be interacted with boiling histotripsy, for example. And now there's also studies that are looking at what are the capabilities of immune checkpoint blockade, in particular I have absolutely no control over what's going on here. It seems to be on an automatic cycle. Immune checkpoint blockade and how that can be integrated. And the last thing I wanted to highlight on that slide was being some very provocative studies as we look back in the literature about whether low-intensity focused ultrasound has capabilities of supporting immunity to cancer. So our primary focus has been using ablative technologies, but there are some opportunities for low-intensity technologies or low-intensity exposure of focused ultrasound to initiate immune responses. So I think what I'd love to start off with is just in the first few minutes of each of our panelists, I told them I was going to say, task them with say, what's the most exciting thing that's come out of their lab over the last couple of years? So that's bringing us up to speed with thinking about what are the people in the trenches really thinking about in terms of the most exciting information that's come out. And then we have some questions which I've formatted here that I think we come to a degree there's a certain consensus about barriers, and then what are the opportunities, what are the burning questions that we need to solve. So maybe if we could start with, let's invite our West Coasters as they are wide awake now. Maybe with Dr. Ferrara, what would you say might be the most exciting information that has come out of your lab in the last couple of years about cancer immunotherapy and focused ultrasound?
Yeah, so I would say that we've been particularly excited about the addition of various immune adjuvants to our therapy. So in the past, we've looked at CPG as a component of a treatment protocol, and in recent times, we've been looking at anti-CD40 as a component. We've observed, and we've looked primarily with thermal ablation at what could you do to be able to combine these techniques together, as well as checkpoint inhibitors. And what we've found has been that if we have the immune system stimulated and ready to go, and we use an ultrasound treatment protocol that adequately heats a large enough region to heat fix areas that are not well perfused, but allow for mild hyperthermia in a rim at the outside of the tumor, that combination could be very effective across a number of different cancers. So we've been very excited to find that those combinations can be effective. The other piece of information that was presented at this meeting by my group was that we were directly comparing a clinically relevant mouse model that is very similar to breast adenocarcinoma, HER2-positive breast adenocarcinoma, to pancreatic cancer, and finding that there were very significant differences in the cytokines, the blood circulating cytokines, and the inflammatory impact of the two treatments. And in part that's due to the immune system, but in part it's also due to the density of tumor cells in the environment, and that we found that with a very dense tumor environment, such as you might see in an adenocarcinoma, that the release of cytokines could be highly inflammatory, and so you need to take that into account. Whereas in pancreatic cancer, where there's more stroma, that effect was not so pronounced. So those are, I would say, those are the things that we've been most interested in as we try to move forward with other protocols.
So that's a fascinating series of observations, and Dr. Allen from Virginia Tech is an expert on acute inflammation in the inflammasome. So, Koi, if I could ask you to sort of chime in at this point, what do you think, why are we needing, so this is the first question, why are we needing PAMPs, CPGs, and or CD40 stimulation, for example, to promote the activity, the immunogenicity of the different focused ultrasound regimens?
Sure, and let me say hello from Hawaii, Tim. That's why I'm not actually there in person. Not to rub that in. One of the interesting things about focused ultrasound and many of these ablation modalities, especially these non-thermal ablation, non-ionizing ablation modalities, is that they release damps, and you mentioned those in your introduction. These damps are important for driving inflammatory cell death. They are released during inflammatory cell death. They can drive or initiate inflammatory cell death, and it's the type of cell death that really does matter here. And one of the things that we're finding are that not all cell death is equal. We have everything from apoptosis to necrosis and many steps in between. But one of the things that we're finding that you mentioned in terms of the inflammasome is the role of pyroptosis. So having the right kind of cell death is really important. With things like histotripsy, where the cells are just ablated, those cells are gone, but it's how those neighboring cells, how those surviving cells actually respond. And a lot of that is driven through these mechanisms like pyroptosis, the release of inflammatory cytokines like IL-1 beta. And as you mentioned, those drive things like dendritic cell recruitment and further down the road antigen presentation.
So Kathy's already got go for it, Kathy.
Yeah, so I totally agree. I really appreciate that comment. One of the things that we found when we did transcriptomics with the addition of CD40 with the addition of CPG, was that genes that resulted in blocking apoptotic pathways in tumor cells were eliminated, or that those pathways then became active. And so we saw a shift. If CPG was given ahead of time, then we saw a shift from the tumor cells dying by thermal necrosis in one case to apoptosis in another case. And so we did find that those mechanisms of cell death could be influenced by the drugs that we gave prior to the ablation. And that may be one of the reasons that we saw a more successful treatment.
Yeah, and when you have CPG, and whenever you're stimulating toll-like receptors, whenever you're stimulating pattern recognition receptors, that can have a lot of really nice effects on the tumor microenvironment itself, shifting that cold tumor or that anti-inflammatory tumor microenvironment to one that's more hot, or one that's more pro-inflammatory and conducive to further inflammation. We got to remember, inflammation is not always bad. Inflammation can be really good at driving both innate and adaptive immune responses.
That's a great point, both of you. And I'd like to point out there's a talk, BST number 7 by Wen Yuz, who's looking at sonodynamic therapy with imiquimod and focused ultrasound. And we were discussing yesterday a little bit about what are the qualities of cell death that occur with sonodynamic therapy, what type of apoptosis is going. So I think that's going to be very relevant there. So if I can just turn for the moment to Dr. Joe. You've been looking at the transcriptomics of, and this is also another poster by Scott Burks, I believe it is, BST2, looking at the characteristics of how different tumor types respond to the same treatment. And it raises the really interesting question if are different tumor types and potentially even different tumor locations influential in the quality of that innate response and ultimately the adaptive response. And has any insight come out of that for you, Joe?
Well, this is a group effort, and I get asked that question every week at my group meeting. So, because we can't so let me back up. I'm not in a thermal ablation domain. If you look at a Venn diagram, and I'm not in the histotripsy domain. We tend to work in a mechanical domain, and basically what would be relatively a low pressure domain. And I think one thing that people should understand is a lot of our effects occur with less than a total of 1 second worth of sonication in the tissue, which is remarkable that we can get almost 5 days worth of changes as of a result of 1 second of basically pulse focused ultrasound in a flank tumor. Given that and the transcriptomic changes, it's clear that the tumor microenvironment, so if you actually dissect away the melanoma versus a breast cancer, the viscoelastic effects of those tumors are different. They actually behave differently. How they're going to absorb the pressure waves is going to be actually different. And how we stimulate it. When you go back into the dish, for the most part, they all respond the same way. We see increase in calcium flux because of mechanostretch receptors on the surface of the tumor cells. And we see increased ROS as a result of that, produced by the mitochondria and causing cell death. You get it into the flank, you do see a very immediate sort of immune response as well as a pro-inflammatory response with very little alterations in essentially the tumor microenvironment. And that persists for out to 5 days, and it also depends on what size tumor you are sonicating. So if you sonicate a small tumor versus a slightly larger tumor, you get a different type of cell response. But ultimately, you do wind up with a slowing of the growing of tumor cells. So despite the fact that our transcriptomic changes, there's an abstract by Scott Burks at this meeting, which really sort of indicates that even at low pressures, relative low pressures, a low amount of time of sonicating the flank tumor, for instance, we downregulate glucose metabolism in the 4T1, but we upregulate inflammation based upon RNA-seq all the way out to 5 days. Cell signaling is different between the two tumors, yet at the end of the day, when you compare it to control, they are slower growing. And we haven't done an ablation. We haven't done any sort of pharmacological or biological manipulation from the point of view of injecting any checkpoint inhibitors or anything else. So there's something there. And we sort of wanted to occupy the space for the idea that you could ablate, you could do whatever you want, but you want to mop up the you want to treat the unseen tumor burden, and that's what you want to use to do that. The second, I think, important fact that's starting to keep us up is the microbiome and what the effect of the microbiome is on tumor changes and changes in the tumor microenvironment. And it's still surprising that that is going to play a more and more important role as we go forward. There was a recent couple articles in Cell this past couple weeks that showed that people who have worse disease, worse metastatic disease, have candida or some sort of fungal infection in their metastatic disease. Is that going to be something important? There's an article this week that shows that depending upon the oral mucosa and the microbiome in the oral mucosa, you would actually could wind up with worse pancreatic disease compared to people who have a different sort of flora in their mouth. We're going to have to pay attention to that, and that's probably going to going to contribute to our heterogeneity in responses between the different labs and how we do things. Because using identical parameters, you get different transcriptomic results, and actually, in some cases, proteomic results, but wind up with the same outcome. So obviously, I'm not looking in the right place yet. And that's one of the things we're hunting for, is we got to figure out what's causing this change that's across multiple studies at multiple time points, and it's keeping to fairly vanilla tumors, the B16, F10, and the 4T1 system.
That's great. So one of the other important aspects of the immune response against cancer is the ability of the immune cells to traffic back to their tumor microenvironment. And Tatiana, I know you've been looking at boiling histotripsy or plain old histotripsy. I get confused. I'm just a simple immunologist. About the sort of quality of damage that's occurring and the type of inflammation that's occurring. Have you generated any insights in the sort of cytokines that are produced after intervention that could influence the capacity of cells to be recruited to the tumor microenvironment?
So, yes, it is boiling histotripsy in our case, but from what we've seen, the cytokines that are released are fairly similar to the ones released in the other types of histotripsy. So we could talk about just mechanical damage. They are somewhat different from thermal damage. So HMGB1 being one important one that we found was released immediately and causing the recruitment of monocytes and dendritic cells to pretty much immediately to the tumor, as well as fairly rapid arrival of CD8 T cells as well. And I know that other histotripsy groups have seen similar trends, so that release is fairly rapid and fairly consistent. And I'd like to also note that it's, I don't think it's unique to histotripsy per se necessarily, just mechanical damage to cells that would probably be similar to IRE or cryoablation would presumably cause the same damage to the cells and cause similar release of similar cytokines. And the dynamics would probably be similar. So I think it's, this is the place where we could learn something from other modalities, such as cryo or IRE and prior triumphs and failures, so to speak, of those modalities in terms of combination therapies, for instance.
So I think that raises the question, has there been the opportunity to triangulate transcriptomic data from histotripsy approaches, which sort of are beginning to show a certain level of independent ability to elicit adaptive immunity, compared that to thermal ablation approaches with innate adjuvants, to understand, is there a commonality between those two that is the biomarker we're searching for a permissive adaptive immune response? Have you had the chance to look at in any of those data sets yet?
Well, it actually is ongoing right now. There's a comparison study between three groups that are comparing the dynamics of the immune response to histotripsy, boiling histotripsy, and thermal ablation. And so we'll soon have some of the answers to those questions in the context of pancreatic cancer at the moment with Katherine Ferrara's group and Jen Chu's group in Michigan. But not quite yet. Maybe Coy has other ideas on how those can be compared.
Yeah, we're also doing similar types of studies. It's not the really nice study that you all have. You know, we're working within our own group, but the HMGB1 seems to be really important across modalities. Whenever we see a very nice innate signature, a very nice adaptive signature, HMGB1 seems to always come up. It seems to be driving a lot of those responses, and that's across modalities. Well, when I say across modalities, it's across the non-thermal ablation modalities. When we're looking at irreversible electroporation, when we're looking at histotripsy, to some extent cryoablation as well. We don't see that signature when we're looking at some of the more thermal ablation modalities. And so I think that there's something magical there with HMGB1. HMGB1 is a really nice biomarker as well. So hopefully, and I have a deep interest in pancreatic cancer, so I certainly hope that holds up across your studies as well.
So is HMGB1 elevated at the transcriptional level, or is this just been released from the chromatin with destruction of the cells?
We see it protein, I'm sorry. We see it at the protein level, and then we see pathways that are associated with HMGB1 responses. We talked about the pattern recognition receptors. HMGB1, for those that don't know, it's a nuclear protein. Anytime it's found outside of the nucleus, it's a robust damage signal that will drive an innate immune response in the local cells. And I'm sorry, I didn't mean to interrupt.
Oh, no worries. Yeah. So I was about to say pretty much the same thing. So if you're ripping a cell apart, it will fall out, essentially.
So it sounds like HMGB1 could be a nucleating biomarker we should start all be looking at. And so Awndre, you've begun to look at spatial profiling of tumors. Could you sort of help us understand how you think that information is going to be useful for understanding how different regimens, whether it's the different ablation approaches, could be perceived differently at a spatial level rather than just at a global cellular level?
Yeah. So for me, I think some of the most exciting data I've seen that's coming out of this field is that in the ablative context, you see this vast infiltration and accumulation of immune cells around the margins of these tumors. And I think there's a lot of opportunity there to get a better sense, and a lot of work that needs to be done to understand the identity of these cells and also their various activation states. And so we know things like there are increases in CD11C, Ly6G, CD8 signatures, which correspond with dendritic cells, neutrophils or myeloid-derived suppressor cells and T cells, but we don't necessarily know the kinetics or temporal regulation of these types of relationships. And why we would care about the co-localization of these types of these immune cells is we do know that in cases such as like in triple-negative breast cancer, that high degrees of immune cell co-localization is associated with improved patient outcomes. And so it's interesting to think that, can we potentially use focused ultrasound to kind of drive and force this type of co-localization and to facilitate the type of crosstalk that needs to occur that might lead to between like dendritic cells and CD8s, for instance, that may lead to the priming or repriming within the tumor microenvironment. And it's, I think, important to keep investigating and appreciate the fact that the tumor site itself could potentially act as a very critical location for immune cell priming in general. We already know this happens to a certain degree just by the existence of things such as like tertiary lymphoid structures that you can find in tumors. These are like areas where you have essentially like germinal B cell reactions within the tumor parenchyma that are also associated with improved patient outcome, but the only way to the way that we got to that data and appreciating that is by understanding the actual spatial context of these immune cells. It's not something you can do with bulk tumor homogenate. So I think it's going with the advent of these really powerful spatial omics technologies that allow us to sequence basically immune cells at a single cell level in a very precise, spatially oriented manner. Is going to allow us to dig deeper and get a sense of how the what those immune cells are and essentially their activation states, and get a better understanding of how thermal focused ultrasound versus like mechanical focused ultrasound may differ in their potential to recruit those subsets. So
it seems to me that that's one of the great unknowns with the state of the field with respect to different ablation regimens or pressure regimens. How does the tissue reorganize as a function of that insult? And how do, in fact, even the non-immune cells, the fibroblasts, the other stromal cells, perceive those insults and respond to them? And what are the cytokines that are produced with respect to tissue remodeling as a consequence? So another tremendous opportunity for focused ultrasound is opening of blood-brain barriers and allowing the brain to be more accessible to a variety of different immunological interventions. And there's a nice poster, BRT17, which is a study that is looking how microglia respond to the opening of the blood-brain barrier of microbubbles. But Dr. Shen, you've already started pushing the boundaries a little bit in terms of understanding how different tumors in the brain respond to focused ultrasound and how opening that blood-brain barrier may make them more permissive to, say, checkpoint immunotherapy. Maybe you could bring us up to speed with what you've discovered in that space.
Sure. So the work I mostly do is on GBM. So we started this project using checkpoint blocker anti-PD-1, pair them with focused ultrasound blood-brain barrier opening pulses. And initially, we thought it was just, we get all anti-PD-1, we got more anti-PD-1 in. And gradually we realized it's more of like immunomodulation, because I talked with several folks who have been using anti-PD-1, anti-PD-L1, who's doing similar treatment. There's a big problem of choosing the models. I totally agree with Dr. Joe Frank. So I'm pretty sure all the audience here who have been working on this field have been used GL261, which is a very popular GBM model. Mouse model, and this model is invasive. This model is necrotic. However, it's highly vascularized, so which possibly is why in the early literature they see a lot of response in just anti-PD-1 only, and many folks told me we see a lot of response in the anti-PD-1 only group, but if you add ultrasound, there's no significant differences. That's possibly why. So there's other kinds of models like CD2A, which carries, I'm pretty sure if I don't misunderstand, it's a very low mutational load. There's also a model, I remember there's a paper coming out from Nature Communications comparing all this mouse models, and then they did all kinds of analysis to check which one is more closer to the human GBM. So another thing I want to point out, I am glad you highlight this microglia activation. I think it's from University of Victoria. So they talk about the dynamic changes of this activation. So from my experience, even though we're pretty much targeting T cells, because of anti-PD-1, we think we can influx a lot of T cells because GBM is very cold, there's not much T cells. However, we see microglia activation, we see macrophages, which is a big part of the immunosuppressive environment in the brain. And clearly, it's time point dependent. So there's a big question of whether we can sustainably, or we can say sustain the polarization of those phagocytes. I think that's something we definitely can work on in the future. And then there's a big problem or question echoing Dr. Joe Frank about the time points or the dosing and scheduling. And once we do the focused ultrasound treatment, how or when are we comparing those, immunotherapeutics? Another one interesting talk I found from actually Yu Tong. She's sitting there from Costa's group at Georgia Tech. So they found, it's actually ultrasound frequency dependent. If I remember correctly, it's related to the shear stress, and then they found some overexpression in ICAM1. So I do think that's something worth exploring as well about the focused ultrasound parameters.
So you think it's way more than just getting more antibody in?
It's
there's
way
going to
more
be a
than that.
combination therapy.
Yes.
Well, there's going to be that sort of spontaneous response to opening the blood-brain barrier that's going to change the endothelium, allow more trafficking. And we need to
Clearly,
map.
yes.
Joe, you had some insights not that long ago about how opening the blood-brain barrier can influence.
I mean, even across not only if we get out of the brain, but even in tumors, we have to also spend a good deal of time of how the endothelial cell, which is basically, your first basically cell surface that actually any sort of immune cell is going to interact with. How are you activating that in order to get your cells, get your immune cells, your innate or adaptive immune cell population into the tissue? So those are the cells you really want to activate. And like you said, we've seen trafficking of the monocytes into the brain. And although what's interesting, at least in the normal brain, we haven't seen with 2 different models of opening the blood-brain barrier, haven't seen a T-cell infiltration, which is actually good because you really don't want in the normal brain that to happen and sort of cell death. But we do see the microglia change over time. And I think that's really how you're going to perpetuate that, or how are you going to potentially keep that up in a way that you can actually cause more glioma death, and whether or not it will behave exactly the same way depending on which tumor type you have. And that's going to be really important at this point, because the brain, as compared to the flank tumors and everything else where you can't do a direct injection, you have a real other issue here of a delivery. But yeah, I think we need to spend a little bit more time understanding the endothelial cell dynamics, the vascular dynamics in the tumors, and then try to figure out whether or not those can be activated, whether or not it's with a bubble, and maybe a bubble in sort of not in the brain. I mean, I think we haven't explored that enough. You know, solar dynamic therapy is trying that, but I think we need to explore how we can activate it and lower the pressures or prolong the therapy, you know.
Yeah. I mean, and it's not just endothelial cell activation, it's as we think about the quality of the endothelial cells, the leakiness that occurs with them, and the programming of those endothelial cells in terms of, are they capable of supporting trafficking? Are they capable of permitting antibodies to access what happens to the osmotic pressure of the tumors that influence these outcomes? I think it's one of the important things, though, as a community, we tend to focus on successes, and we don't spend enough time analyzing lack of success. And there's a paper from Sarah Johnson's group, IMM11, where she used anti-PD-1 with a PY middle T version of breast cancer and thermal ablation, where she didn't see much improvement. I think it's really important to start bringing in studies like that to understand why a predicted response is not working. And then, Kathy, you've had some experience looking at an NVL model versus a PDAC model, and you've seen successes in some models and not in others. And do you have sort of insights that you can share about what studying those 2 models has provided you information in terms of what are the qualities of the response, both negative and positive, that predict lack of tumor control?
Yeah, well, for us, it has been that if we add in some kind of an adjuvant that's selected based on the single cell sequencing of the tumor itself, then we are able to impact response. But specifically comparing those 2 tumor types, we found that there is so much more of an inflammatory effect in the NDL breast tumor, which is basically a transplantable model of the PYMT, so very similar to PYMT in terms of its biology. And in that very dense tumor environment, we found there were very large amounts of IL-6 that were upregulated as a gene, but even circulating as a protein in the blood. And the other thing that was a little surprising to me was also leptin, likely due to the ablation of some of the fat cells in the region as well, was also circulating in the blood. So those very intense inflammatory signals are very different between the 2 models and in terms of the effect of ablation. So I think that has to be taken into account in terms of how you set up the immune environment before you perform the ablation, and how you combine different parts of the treatment to take advantage of the good and bad effects of inflammation that are going to result.
Corey, do you have anything you'd like to add? You've looked at lots of models and had successes and failures in different ones.
Oh, absolutely, yeah. I mean, everything you all are saying is consistent with things that we've seen as well. Really, for us, controlling the tumor microenvironment and modulating that is essential. And not all tumors are the same. We are beginning to investigate the changes that happen within each tumor following ultrasound, following histotripsy, following irreversible electroporation and H-fire. And finding that the tumors are upregulating anti-inflammatory markers, anti-inflammatory signals, some of them, but not all of them. And so really defining, what are the key markers that are being upregulated in each tumor type is going to be important to understand why some treatments succeed and some treatments fail. For example, we've done some work comparing breast cancer and pancreatic cancer and found that in pancreatic cancer, we're not getting as robust of a systemic anti-tumor response. And we found that that's because of some of the cytokines, some of the chemokines that are released by the tumors are upregulating things like PD-L1 in the tumor. So we have a tumor that wasn't PD-L1 positive, and when we treat it with something like focused ultrasound or histotripsy, we see that those tumors increase PD-L1 expression at the tumor level. And so we're beginning to tease apart some of the differences in those tumors that drive some of those responses.
So we've just got a few seconds left to wrap up, and I don't see any questions on the stream. I can't see the microphone, but it looks like there's nobody there. Awndre and Tao and Tatiana, if we could just finish up, what makes you most excited about what's coming down the pipe with focused ultrasound and immunotherapy?
What's coming down the pipe? Most excited, I would say, again, I think there's a lot of work that needs to be done still on the characterization front to really kind of provide that foundation to start launching off some very detailed hypothesis-driven studies. And I think that's kind of where things are going based off a lot of the talks that, so a lot of the submitted talks that I saw over the past few days. So I just kind of encourage everyone to kind of stay the course and keep moving down that front.
Tatiana, what are you most excited about?
Well, I'd say the improved understanding of prior successes and, more importantly, failures, because we've had enough of those as well, in terms of certain interventions not creating immune response that would be expected. And in particular, a shout out to Joe Frank's lab in characterizing mice from different vendors. How much of an effect can that have? Just the same model, same everything, but mice from different vendors and different microbiome and different microenvironment can have such a huge effect. And figuring out how to use that knowledge to have more successes than failures, I guess.
I want to echo their thoughts on the growing appreciation from the foundation, from the general public about this field. It's a very tough question to understand, and then we are experiencing more failures at this stage, but at least we see some more clear directions. From my personal experience, I do think this myeloid, the big myeloid compartment in the brain is something we definitely need to work on. And, it's not just for the GBM, for cancer, and then also for Alzheimer's and maybe PD as well. So I do think that's something exciting.
I think that last point is very well taken, and there's a huge opportunity as we deal with more and more clinical trials, particularly in glioblastoma, as we open up the blood-brain barrier, to use the advantages of FUS for circulating tumor cells, but even circulating myeloid cells, to understand how the tone changes. And as much as possible, we want to encourage collaboration between the trialists and the preclinical researchers to provide insight of that information, extract as much information out of those trials as possible without actually being invasive for the patients. So I think we're out of time. I'm seeing a red blinky light there, which generally is not a good thing. It's blinking at me. I have a problem with red lights. I just go straight through them. I think, so I'd like to thank the panelists and for their time and providing their feedback in what is clearly a nascent but still a very exciting field where focused ultrasound intersects with cancer immunology.